Welcome, everybody. We're delighted to have you join us today at the CMSS virtual annual meeting. I'm Dr. Helen Burston, the CEO of the Council of Medical Specialty Societies. I'm really thrilled to have you join us today on our meeting around beyond COVID-19, we hope, the digital transformation of healthcare research and education. For those of you who don't know, and particularly some of our guests, this is CMSS. We are a coalition of 45 specialty societies across the House of Medicine, representing more than 800,000 individual members of those societies. And we really see this as a huge opportunity for us to come together on topics like this and move the dialogue forward. On the next slide, you'll see our mission statement, newly redone in the last year or so, three-part mission to support and strengthen specialty societies to meet future challenges, many of which we'll talk about at this meeting, to catalyze improvement through convening, collaboration, collective voice, and action across our societies. And then finally, to provide a proactive platform, really a think tank function, to assess and address emerging and critical issues across specialty societies that influence the future of healthcare and, very importantly, the patients we serve. Next slide. So we want to just open briefly by sharing our two strategic priorities for the year, both of which have been addressed in some form at this meeting: diversity, equity, inclusion, anti-racism, and digital transformation. In our diversity, equity, inclusion, anti-racism efforts, we're really looking at trying to come up with innovative pathway programs across the societies to try to increase the number of those underrepresented in medicine. We want to support inclusion, mentorship, and engagement of those folks into our specialist society leadership. And really importantly, and the one we've added, is developing an anti-racism collaborative, and I would add curriculum, across our society to identify effective strategies to counter structural racism in healthcare and the medical profession. And the second one is digital transformation, the topic of this meeting. We're really thrilled we have a chance to address it in this way, thinking about how we can get specialty societies engaged and at the table as new and emerging digital systems are designed and developed. How do we have a shared repository of what are all these new terms and things emerging around digital transformation, around machine learning, AI, the cloud, for example. And really importantly, we've got a couple sessions on this. What is a set of principles on safe and ethical and effective use of digital tools that keep the patients first and foremost as our North Star and safe? Also, how do we think about collaborative efforts to share effective strategies to digitally transform clinical registries? There'll be several sessions on that at our meeting over the next couple of days. And the next two were added as a result after the pandemic, and so much that has changed over the last 8 months. The next one is really thinking about sharing effective strategies around successful adoption and implementation of telehealth, virtual care, remote patient monitoring across our societies. And then finally, a big portion of this coming up sessions, identify and share effective strategies to support digital transformation of virtual education and learning. So on the next slide, just to highlight, we're really delighted last night that we're able to kick off our a priority area on diversity, equity, inclusion, anti-racism with a just riveting session from Dr. Rhea Boyd, who presented on racism and helped us really think through what our societies need to do to make substantive progress in addressing racism, ably moderated by Patricia Turner, a member of the CMSS Board of Directors and the Director of Member Engagement at the American College of Surgeons. Next slide. And then lastly, this is the opportunity for us over the next couple of days to really think hard about how our priorities around digital transformation fit into the bigger picture. You'll see sessions over the next 2 days that really will address all of these issues around privacy and security, next generation registries, what are the next tools we'll see, how to be effective telehealth, and an entire track focused on this important pivot that many of our societies have made this year around having to move in-person meetings to virtual meetings. And not only just making that not only just making that transition, but also thinking about how to do it that takes technology as a useful tool and moves it forward in ways we never could have imagined before the pandemic, and thinking about how to share effective strategies across our societies and with thought leaders in the education space. Next slide. So just want to thank PCORI, who's our program sponsor for this meeting. Delighted to have them engaging with us in this meeting. They have a special session this afternoon on how to get evidence into practice, really thinking about what are those effective strategies to take what is emerging out of these new digital research enterprises and really get it out there in ways that make a difference for clinicians and for patients, as well as delighted to have Dr. Nikayla Cook, the relatively new director of PCORI, in our closing session tomorrow afternoon. Next slide. And also, of course, want to thank our industry partners who work with us throughout the year, really helping our societies think through what are potential opportunities for us, particularly in the research space and beyond. So next slide. A little transition. There we go. We're going to, as we have this meeting, we are going to have hopefully some great discussions on Twitter. And I would ask you to use hashtag DigitalMed2020. We do have on the platform 2 features I want to make sure you note, one of which is to chat. We'd love to see you engage and chat with each other and have ideas about what else we could do in the future, or how what you're learning from each other, as well as a Q&A feature. So please feel free to at any point enter questions in the chat box. We'll be monitoring the chat, the Q&A section, I'm sorry. We'll be monitoring that Q&A box and share that with our speakers, as I will have the honor to do this morning for our opening keynote. Next slide. So just a final word before I turn to Ms. Cryer's opening session. We are delighted that at our CEO Council just yesterday, we approved our new CMSS Board of Directors, and delighted that Dr. Darylyn Moyer, the EVP and CEO of the American College of Physicians, is our incoming president, and also very delighted to have really an extraordinary year with Todd Ibrahim, the EVP at the American Society of Nephrology, at our helm. So just want to take this public opportunity to thank Todd for his incredible service to CMSS over the year. And I'm thrilled that we get to keep him another year as immediate past president. And I'm sure we'll find lots of other things to keep him engaged. Marty Liggett, the head of the American Society of Hematology, is the new president-elect that will follow Darylyn. Members of our board are included here: Dr. Bill Thorworth, American College of Radiology; Patricia Turner, who I mentioned, the American College of Surgeons; Tom Stotzenbach, American Association of PM&R; Sue Sidori, the relatively new CEO of the American College of Emergency Physicians, who we won't get to have with us this week because they're having their meeting as we speak. Dr. Maureen Phipps, the not so new CEO of the American College of Obstetrics and Gynecology. And finally, last but certainly not least, our opening keynote for this morning, Ms. Donna Cryer. Let me just take a quick moment and see if Darylyn and Todd want to say any words before I introduce Donna and have our session moving ahead. Thanks.
Well, thank you. Go ahead.
Go ahead, Todd.
No, go ahead.
Age before beauty, Todd.
I can only get myself in trouble, I think. Just to thank Helen and the entire team at CMSS for just an extraordinary year. And I think the meeting really does outline all of the key issues in terms of responding to the COVID-19 pandemic, addressing issues related to racism in healthcare and in medicine, and finally, really thinking about how this new digital world, which has been accelerated this year in ways that none of us could have imagined 9 months ago, really will affect everything we do from an association perspective, but also from a healthcare perspective. Also, just to thank Darylyn for all of her support this year. She's an extraordinary person, and the fact that she's an ID doc has been extra helpful in terms of answering any questions we may have about the pandemic. But I think more importantly, just as a human, she's just someone that I can always rely on for telling the truth, but also doing the right thing and just being there each step of the way, as we've tried to navigate a lot of things this year. So just to thank her, to thank Helen, to congratulate Donna for joining the board, and looking forward to working with her during the next year and beyond. So thank you.
Thank you, Todd. You may want to hold off on those thanks until you see my bill. But seriously, it has been just a very challenging but wondrous time to be in healthcare. And I'm so proud of the way our entire healthcare um, group of professionals, healthcare institutions, organizations have really stepped up in terms of COVID and what will be beyond COVID. And I do think one of the silver linings of this has been how much closer I am seeing our organizations work together. And I just want to end by saying my final thanks to Helen and to the CMSS team and to all the fellow and lady CEOs of the other organizations in CMSS. Thank you, and I very much look forward to your talk.
Wonderful. Thank you to you both. So next slide, I have the great pleasure now of introducing our opening plenary speaker, Donna Cryer, who I've had the great fortune to know over several years. She is the founder and chief executive officer of the Global Liver Institute, a patient-focused institute on those suffering from liver disease. She herself, as she will share with you, is a liver transplant recipient. She's done just so many remarkable things as a patient advocate, including being a patient representative to the FDA. She was the former interim executive director of the People Powered Research Foundation of PCORI and still remains very engaged with PCORI. A member of the board of directors of several organizations, including Sibley Memorial Hospital and Johns Hopkins here in Washington, D.C. And as I've mentioned, we're just delighted and thrilled to have Donna as the new public member of the CMSS board of directors. So with that, I'm going to turn the proverbial screen over to Donna, and thank you again.
Thank you so much. I am so honored to be joining this organization and this board at this time. It is for someone who has, is only alive today, personally and professionally, because I have taken advantage of the skills of all of the specialties, and that includes internal medicine. I am really excited to be able to serve in this way. And I am particularly excited to be part of this meeting on digital transformation. As I thought about preparing my remarks for today, and also doing a little pandemic decluttering, it dawned on me how much I have been honored to be both a witness and participant across this history of digital transformation in healthcare. As we all know, change starts first with the self. So I'll start with my experience with digital healthcare as it was at the time from a personal perspective. So, newly minted transplant recipient, I was assigned actually in my first job with the United Network for Organ Sharing to learn what what other patients were talking about and discussing. So I was introduced to this concept of an online bulletin board, and I sat in my apartment in Arlington, Virginia, and used a dial-up modem, for those of you who remember that, to sign on to what we now would recognize as something very, very primitive, but something very potentially powerful. There I learned that other patients at different transplant centers were coming off of their prednisone. And I touched my face for all of you who've been on prednisone and know what that does to one's face. So I went back to my care team and asked them, could I possibly come off of prednisone? And they said, sure, why not? Why don't we give it a try? That was an aha moment for me. That was my realization that what was happening in this virtual environment, this digital environment, was something that could change my real life, could transform the quality and content of the conversations I was having with my physicians and the decision making that we were doing together. fast forward a little bit to the emergence of the sort of dawn of the e-patient. Did that simply mean electronic, or was it about being equipped and empowered and enabled to partner in your healthcare? And the creation of Society for Participatory Medicine, which has been such a force in so many of the early patient activists that you know so well across the ecosystem, started at this time. And so finding that there were other patients who wanted to use Twitter, who wanted to use digital media to share information and help other patients was so exciting. The ability to formalize that and add my legal training to my lived experience as a patient on the launch of the consumer engagement campaign and infrastructure at HHS, and serve first on the Security and Privacy Committee, and then on the full committee for the HIT Policy Committee, advising the Office of the National Coordinator on HIT, was a wonderful introduction and a transition point from a patient, even a patient advocate, to the role that patients could have in policymaking, and how we could both transcend and transform our experience into policy positions that would help all in this digital space. I was honored, as Dr. Burstein mentioned, to serve as the interim executive director for the People-Centered Research Foundation, PCRF, and the leadership of PCORNet. So to work across academic medical centers, payers, and patient experts in communities to create a new way of doing research that wasn't so siloed. And this is something I'll come back to in my remark. Is remarkable. And then today, certainly, being a part of the Council of Medical Specialty Societies and leading the Global Liver Institute, which allows me to be in contact with thousands of patients, certainly online, but around the world, in different health systems, in different health circumstances, and how to think, how can we use this new technology to improve patient outcomes and patient experiences across the world is an exciting proposition. So that's sort of my trajectory and the context in which I speak to you today. So I believe that there are 4 principles that are essential for patient-centric digital transformation of healthcare. And I say patient-centric because, well, what other type of transformation would we want? I do think it bears saying from time to time, though. But during the course of this conference and many other conferences, of course, you will hear many highly technical, legal and clinical terms, acronyms, some things like that you won't even know whether they're medical, legal, or technical. We can talk smart on fire and other things, GDPR. And some things can sometimes be intimidating, certainly for patients, but also for physicians, and lead them to think that they can't contribute to digital change and to drive digital transformation. But if patients and physicians aren't in fact doing that, aren't at the forefront of this change, we won't have meaningful solutions. So I thought we would just condense and really I'd focus your attention on 4 essential principles, and keep these in mind as I go through my presentation in the brief time I have with you today, and also through the conference, and hopefully they'll be helpful to you as you attempt to decode and engage with digital transformation after this meeting. The 4 are exchange or interoperability, curation, connection, and convenience. Exchange, curation, connection, and convenience. And I'll go into more detail. So, we don't know if we have the right answer to something if we don't know what problem we're trying to solve for. So I think that the digital technology is uniquely qualified to solve the problem of fragmentation for patients, and the potential for digital to pull the pieces together for the patient is really what will be transformative. So when I speak about exchange and interoperability, I want to talk about the concept of having one patient, one record. And if this list looks much like a wish list, it is. This is my personal wish list after being involved in this space for a number of decades. But I think we're coming closer to realities in all of these cases. So one patient, one record, a record that's centered around me rather than a health system or other actors. And I think that has the potential, because this meeting is about healthcare, research, and education, I think this has the potential, if we have that one record, of being transformed from one patient into thinking about many patients and having meaningful registries rather than the silos we have today. But to do that, we need a different way of thinking about exchange technology, interoperability, rules, and guidelines for the road. The second concept is curation. And I'll walk you through my sense of what a personalized patient dashboard could do for certainly someone like me, who has multiple concurrent conditions, all of them quite serious. But when we think about 41% of the American public has 2 or more chronic conditions, that really is, we're really talking about something that everyone needs to have the pieces pulled together more tightly. When we think about curation, there is a flood of information. How can we make it into a stream and pull out those pieces that are meaningful, useful, and actionable for people? So I'll give you a sense of my ideas for a personalized patient dashboard that might be useful. Connection. Certainly, we've seen the power of patient communities, from that very early stage on a simple bulletin board to patients like me, to Facebook communities, to communities that are part of patient advocacy organizations. The power of connection, not only of patients to each other, but of patients to other stakeholders, is an important part of this transformation. And then convenience. So certainly COVID has accelerated this concept of telemedicine and bringing healthcare more conveniently to the patient in a way that we never, well, several of us wanted it and hoped for, but we didn't expect it in 2020. So it's very exciting. So rethinking records and registries. So on that idea of exchange and expanding upon that. So, we have been mired for so long in what is the right business model for a unified patient record and who owns the data. And I won't devolve the conversation into that today. But as someone who has multiple patient portals at multiple doctors' offices, and who does access them regularly because I have crucial lab values, crucial imaging, crucial time-dependent actions that need to be taken based on the information within these portals. Someone far more clever than I am coined the term portalitis as a condition that we now suffer from across these different portals. Whether it's an intended or unintended consequence of how the early meaningful use and other pieces of legislation and statute were set up. We certainly know, or I can tell you from the patient experience, it's not working for us. I don't think it's working for physicians as well. It's certainly not working for research. So whether we come up with a unique patient identifier or blockchain or something, the essential concept of me as a patient having one record is so important. Briefly, when Sibley Hospital, that I now have the honor of sitting on the board, became part of Johns Hopkins Medicine, where I had originally received my transplant 26 years ago, when our EHRs were joined, magically, all of my patient records from that time to this became reacquainted with each other. And so we started seeing trend lines across decades that have allowed us to understand, and personalize my care today. So it's a very clinically important concept, and it's, I think, an ethically important concept as well, to have one record for one patient rather than what we have now. The integration of patient-generated health data is so important to make sure that this one record actually reflects the fullness of my life and my activities outside of the clinic. And so whether it is a wearable, a sensor, a mobile app, which is, I put in one category, sort of more active and I think more highly developed into how that starts to integrate with the medical record and how we start to use that data to guide care. But we're also needing to come to terms with how do we use social media, data about consumer behavior, geolocation data, which have an entirely different set of privacy sensitivities and security to them. But they, as we've seen from COVID tracking, for example, it potentially very powerful. And then the third component of this exchange that I feel is important, and you'll hear much more about it during the course of the conference in terms of thinking about registries as a dynamic capability of queries across a sea of this data that comes from many patients at many different institutions, in many different organizations, rather than in a silo for, as a patient who has multiple diseases, I want to make sure that that research is able to find me or find my genetic samples or other information to be able to create cures for any of the types of diseases that I have or types that I don't, that my information might be helpful for. So rethinking records and registries as a dynamic capability rather than fragmented silos for single purposes, I think is very important. So here it is, so the curation part. There's so much information coming through particularly for complex patients and the physicians who treat them. And so on the left is just a generic dashboard to give you an idea of what I'm talking about, because I really am talking about a dashboard. If I'm the patient and driving my care, and I do, I need the information, but not all of the information that's sloshing around. I need the relevant, important, actionable pieces of information. And I want to sort of give you just some ideas of what that may be from my perspective and lived experience. So, when I pull it up in the morning, could there be, a greeting, as there frankly is on my digital scale, which also has the date and the weather and things like that. But an overall health scale, a visual trend. So, am I healthier than I was a month ago, a year ago, or are we sort of on the downswing? That's meaningful to know. What's my starting point today? How much work will I have to do as a patient to get myself to at optimal levels? Do I have upcoming appointments? Are there alerts? Do I have a colonoscopy coming up and need to be on clear liquids or stop taking iron? What is the checklist of my health actions today? Get on my Peloton, lift some weights. Are there prescription refills or medical bills in my mailbox? Are there journal articles or blogs or websites that I should be reading that are personalized and curated just for the set of conditions that I have? I am fortunate enough to have a physician researcher husband who circles key JAMA articles and New England Journal of Medical articles every time they come in, because yes, we do get it delivered to the house in paper still, as much as we're fans of digital transformation. But what if every patient had that, maybe not their own personal physician, but some AI feature delivering a personalized reading list to them? Are there research opportunities, clinical trial matches? Are there advocacy opportunities that I, as a patient, could be lending my voice to, and my talents and professional experience to? And are there communities that I'm a part of that have relevant conversations that I need to contribute to or would benefit from hearing in a way that is more easily digestible and actionable for me? So this is what I mean when I talk about curation. So the power and purpose of connection. Community is a word that is thrown around amongst patient advocacy organizations, and I'll have to admit that for as many conditions that I have, I wasn't a part of any support group that I wasn't a speaker. That just isn't sort of how I was wired. But online, having access and perhaps a from my home in an easier fashion, an asynchronous fashion, certainly in the middle of the night when people are asking questions. I'm able to be part of so many different communities and so many different insights from people around the world, and so many different ways of being a patient and experiencing care and experiencing living with different conditions and different combinations of conditions. And so, patients participate in community, and the benefits of community, particularly digital communities, is different. And so I think we need to be strategic about often what we're asking from it. Are patients seeking support from it, from peer mentors or others who are a little further down the road? Are they seeking exchanges about treatment experiences and the latest clinical trials? And we've seen, trials arising from online patient communities as those exchanges of treatment experiences and questions come. And then research communities, certainly research communities, online surveys, registries that emerge from patient communities and organizations have driven all the way to treatments and cures for diseases. But I think we need to be mindful what we are looking for when we want to interact with different communities. And so in this age of COVID-19 and a global pandemic that has certainly accelerated so much of the transformation, so many of the digital tools and patient-centric innovations that many of us have called for such a long period of time. It has created as much opportunity, which I guess is the other side of chaos, as there is challenge. And so one of the things that I wanted to know, particularly for this audience, is that I think the exercise of physicians across practices, across health systems, looking through their panels of patients and really in an individualized way, thinking through, even more so than the advent of population health thinking spurred, but really thinking through what was the risk of a patient of coming into the office, and what were their needs, and that risk and need stratification and how those patients could be best served in the safest fashion, in the most efficient fashion, is something that I think will hopefully transform our care and thinking of how we serve patients and deliver care moving forward. Certainly, telemedicine has given a more holistic view of patients, very literally. To hear the comments from so many physicians who hadn't used telemedicine before, getting that view into their patient's home, their family members passing by, the soda bottle that's sitting next to them when they say that they drink only water. Seeing patients, gate in their normal environment, just that insight into the whole person that telemedicine has provided. I think it's creating a lot of aha moments. I look forward to hearing from more physicians about how it's changing their desire and perceptions of how care could and should be delivered based on their experiences with telemedicine, which has risen exponentially from, some systems or practices doing, 10 visits a month to 10,000. We've seen explosions of home health care. I've received everything from, nurses bringing IV, care to my home, and the need for that accelerating, I think is really important to centering care around the patient. So often before, when we talked about patient-centered care, I felt more like the target rather than really the primary concern, or the organizing element of care. But COVID-19 and the necessities have really driven the adding staff to home health care and the expanding the number and type of patients that could be served at home even better. And we've seen decentralized trials, whether you call them hybrid trials, or it could be something as simple as delivery of the trial medications to a home, or really the digitalization of trials, of everything from e-consent and the entire trial, once they're sort of rethought and restarted for this sort of long haul that we know, this marathon, not a sprint, that we know is this pandemic environment. And so the thought of decentralized trials is very exciting from a patient perspective. And then I want to distinguish digital therapeutics. So often telemedicine is just seen as the visits, or home health care is some of the physical or just remote monitoring from the digital. But digital therapeutics, really making interventions in the whole. So using the digital information and the verbal and other information that a patient is providing, and providing actual care in the home through technology, through wearables, sensors, through CGMs, through other mechanisms, through virtual asthma with counts that are connected to the record. Looking at virtual reality in psychotherapy, there's so much that we can bring in terms of actual the actual marriage of the digital with the therapeutic side, that I think we're just starting to explore because of COVID. And so, what is the future of digital health? I look forward to participating in the rest of this meeting to understand more what that can be. But I know that very soon we will just be talking about it as health rather than digital health, that this will be the way that healthcare is delivered, or at least such a significant component of it. I certainly don't want to discount the physical exam or the face-to-face interactions, with the medical team. In fact, the only interactions I've had besides, my bank and CVS during this pandemic have been with nurses and physicians who have redesigned their healthcare, the healthcare environment to still be able to deliver the care that I need, because, we know that patients' conditions don't stop just because of the pandemic, and that there are other health conditions that are proceeding in addition to COVID-19. And so I'm so grateful that for the IRL, in real life interactions that I've been able to have with healthcare systems, with nurses and physicians, across my various specialties. But I think that digital health, whether it's telemedicine, provision of information, this concept of exchanging data in new ways that flow with the patient, curating the information so it's more actionable for me as a patient, for my care team, and also for with the right privacy and security settings for other stakeholders in the ecosystem, most especially researchers. Connecting. How exciting is it that we are connecting today, even during a pandemic, from our homes or offices, to still be able to have these conversations? So connection is so important to the future of digital health. And then I'll still put a plug in as the patient for convenience, when it is less of a burden for me as a patient to take care of my health and do those actions necessary to create an optimal health environment in the context of taking care of my family, of my friends, of my work, whether it's because I don't have to travel to a doctor's appointment, or because I'm just able to interact and send information to my care team and others online, or pull it together with researchers around the world. When it becomes more convenient for the average person, the average patient, no matter if they are in an urban or rural environment, if they are disabled or elderly, if they have one condition, several conditions, when it becomes easier for us, and it becomes part of the culture for us to be contributing and participating in healthcare conversations and decision making, that will be truly transformative. So thank you so much for allowing me to share my thoughts with you today.
Thank you so much, Donna. It was just remarkable, exactly what we hoped you would do today, and get us in the right mindset. I'm a big fan of having patients open medical meetings. I think it changes the way you view what we're going to talk about for the next couple of days, and always keeping the patient lens front and center, particularly somebody who, like you, unfortunately has had your share of probably seeing many of our member society represented.
Yes, as you were counting, I was like, all of them. Some of us are a little more patient-y than others. So, my husband says, he's like, you're a very smart fellow at this point in your career, as we jump across, gastroenterology and hematology and a little nephrology from time to time. So I'm very, very honored to be a part and play this role.
Great, thank you so much. So I'm thrilled that we've got, just to remind you, go ahead and put some Q&A in the question little box there on the platform, or even chat. And maybe I'll just quickly see if Darylyn or Todd have any reflections.
I'm afraid to get in trouble again with Darylyn.
No, fire away.
So thank you, Donna, for just a tremendous talk. And as Helen, I have the same feeling as Helen, that really is important to start with the patient perspective. Just to build on what you were just saying about all the different specialists you've interacted with, I'm just sort of curious, as you think about the future and the relationship between primary care physicians and subspecialists, as well as kind of integrated delivery systems, and just sort of then the sort of layering on the piece around digital health. And I like your concept of it's healthcare, and the digital piece is just part of it. Just wondering as to, from a patient perspective, how you think all that will change, and that the interactions will be perhaps better for patients than they have been in the past, in terms of a little more continuity and interconnectedness.
Todd, I think that's a very important point, and it is certainly important for me. My ability to, find the right fit with a primary care physician it has just really been instrumental for how healthy I am today. And he really is sort of the coach of this very extended team that we have, but his ability to be that hub of all this information, and he really does that sort of curation function now, and pull out the actionable pieces, and to make sure that everybody's literally on the same page about where we're going for me with my care, having served for many years as like a one-woman HIE, health information exchange. I'm so relieved to have an actual physician in that role, who's looking at that data, who's talking with the other members of the team across different specialties, and making sure that the recommendations are concordant and not, in conflict. So it is really an essential role, but the ability for him to do that job is hampered or hindered by his ability to pull all the records and digital pieces together in a comprehensive and concise way.
Thank you for that wonderful talk. I've heard some people refer, I'm not Jewish, I'm Jewish by marriage, but I've heard some refer to the EHR as the million pixel mishigash, which means basically a mess.
Yeah.
I certainly hope we're all moving to a better place. ACP has been very interested in restoring the story. We actually had a task force on it. There was a recent publication in Annals of Internal Medicine, and hopefully with the E&M coding changes that are getting put into place in 2021, that will hopefully significantly decrease the amount of just really stuff that is useless, redundant, not important for the visit. Hopefully we'll get back to restoring the story. I see that Janice Tufty put a question in the Q&A. She is actually serves on several committees for ACP as our patient representative. How do you think medical societies and the members at the local level and the practices can utilize the power of patients as we hopefully move to, as we move in this digital transformation age, hopefully move back to restoring the story for patients?
I really love that term, restoring the story. I have had the honor of being to ACP headquarters, and I remember having conversations about the importance of a face sheet, and so to my patient mind, when that sort of went away in the early stages of the EHR, my attempt to sort of restore the story, I was to sort of create a paper version of a face sheet that I bring to every visit. So I have sort of this 3-page summary of things to help, because my medical records, you imagine, whether digital or in paper, are you can't get through them and come to what is the question of the day? What is the issue we are trying to deal with today in this 8-minute visit without some assistance? So you're right, the need to restore the story, and for a patient like me to tell a very complex, long story quickly for that physician, is the difference between a very healthy outcome or medical error, and so it's really, really essential to restore that story, to give that context. And I think what medical societies are doing with folks like Janice and I, inviting us into the process, from a governance standpoint on different workshops, working, with us to design care together. I think it makes for much more realistic, solutions that stick, because they're designed with the initial stakeholders. I think that's the problem you saw with, or you see with EHR, is that there weren't enough doctors involved. I remember being on the installation of an EHR at one health system on its very first day. I was sitting at my father's bedside, so I was just observing the nurse as she was going through, and it was ordered in almost the inverse of how she was doing, the physical exam, from head to toe. And I was like, well, why isn't the tool organized in the way that you, the clinician, work? And she said, well, we weren't involved. And then, and I've discovered how little physician and nursing involvement there was in the design of those. And that's a mistake. And so I think that by inviting patients in, medical societies are also helping to solve for the future as we design together. And I think at the local level, certainly I can say, as a leader of a patient advocacy organization that works very closely with our medical society, first at the national level and increasingly at a grassroots level, pairing physicians and patients in communities and hospitals on education pieces, on on how to use the HR and navigation pieces. It's very exciting to create that level of partnership, but it really wouldn't be possible without that sort of organization to organization, patient advocacy organization to medical society intersection and mapping. And that wouldn't have been possible, if you hadn't, you and your colleagues hadn't taken that step to, invite me and, this first generation of patient advocates in these various roles to sit at the same table and talk with you as peers to move forward. So I'm very grateful and very hopeful.
Well, thank you for that answer and your wonderful talk today. And thank you for joining the CMSS board. We're gonna put you to work.
I'm ready. I'm ready.
There are a couple other great questions, Donna. We still have some more time. I'd love to ask you. One of them is from Dr. Bill Thorworth, who's also on our board, the head of the American College of Radiology, and raises the issue that always comes up whenever anybody talks about these questions, which is interoperability. So it's been on the docket forever. We talk about it. There are new rules that come out. We haven't made very much progress. So Bill asks, how can specialty societies drive this agenda ahead? And I would actually maybe slightly modify that as, how can specialty societies together with patients really help drive some of that, what really needs to happen to get to a place where you don't have portalitis, where you don't have to be the keeper of your records, but in fact, I, as your primary care doc, can in fact see what just happened at hematology and your nephrologist and others.
So one step forward, one step backwards. So I had MRE the other day, and the progress was that they said, wait, and we'll give you a CD right away. I didn't have to, request to sign for something. I didn't have to sue them for it. I didn't have to, as I have in the past, sat at one specialist office and tweeted at the health system angrily about their refusal to provide me that information. So that's progress. So they had it right away. They knew it was part of the progress. But I was like, what am I gonna do with this CD? Do I even have a device that has a CD player in it? Does my doctor will their system allow it because they're fear bugs? What am I gonna do with this CD? So the answer is not handing the patient a CD, but I appreciate the thought. If only it was the thought that counted. So to be able to have, a and it's not a future, because this is possible. I've been in, other environments where, I'm having conversations, and it's one of the things I actually love about telemedicine, because I will have multiple screens up, and so I'll be pulling up, my doctor and I will be looking at images together. I'll have lab data up on another screen with some trends, and we're able to have a really robust conversation. So that's possible, that's happening. How do we make that universal? And I think that, I'll speak here from my law background. Um, you know, we need the physicians in policy positions, in policy making, accompanying us as patient advocates in the rulemaking, uh, to ensure that this is how data flows. Being in committees to make sure that it's not just lab values, but the word imaging is there when the legislation is written, so that we make sure that that flows. And in the formats, there are procurement decisions that health systems make. So making sure that we know the needs of imaging for those of us on the board, so that we can make provisions for that in procurement is important. So I'm so excited to be part of CMSS, because your voice is so important. You need to speak up, and it's essential. I mean, as the patient, certainly have a voice, and we have a power and a role that we're just starting to step into. But as a VP of a healthcare system, when I asked him, well, gosh, this is your EHR, everything is awful. I have more information on my phone than you do, connecting your emergency department to the scans and lab work I had just the other day. And I was like, who is the system built for? And he was like, well, it's built for the doctors, it's built for whoever. So we need the doctors. And we'll be right by your side when you're talking to healthcare administration or the board, or policymakers, in describing the system that we want and need. We need your expertise as advocates to know what to advocate for. So I look forward to more conversations with you at board meetings, virtual or in real life, so that you can tell me, the advocate, what you need to make radiology happen better for my patients and for all patients.
Well, Dr. Thorworth has already responded that he'd love your help with our join the hashtag Ditch the Disc project. So it looks like you're in the right place, Donna.
When I use that example.
Perfect.
So
Well,
I'm ready.
yeah, I think there's a great opportunity there. Again, there's something really powerful about patients and clinicians coming together. And I would actually argue that, in your conversations with the health system, those EHRs aren't really built for clinicians either. So they're not built for either of us. So I think one of the core things we put in our new digital transformation initiative was that we need to be at the table and think about the function of the design of those as they're rolled out. So just a couple minutes left. I just want to say there was one question, I think, that was in there a little bit earlier from Janice as well. But I think just this idea that you raised around the fact that you as a patient can reside in multiple clinical registries. So many of our societies do have clinical registries, have made investments in them. Your vision of how you can see them coming together. And it just as an aside, we've already seen, for example, again, this theme of COVID and beyond, many of our societies have in fact come together around COVID registries, critical care medicine, emergency medicine, radiology, labs. So it just your thoughts from the patient viewpoint of, from where you sit, the idea that your data resides in multiple places and how you can get you across that would be a great way to get your final thoughts.
Sure. So there's a legal answer, there's a technical answer, and there's a cultural answer. So and if we'll do them in reverse order, because if there was a culture of sharing, and that's what we saw really move in COVID, there was a desire to solve a problem. And so with that desire, there was a direction to, take out the legal barriers, or solve them or waive them or sign them or create unique collaborations. And then the technical solutions exist to do, overlays to different EHRs to make them talk to each other when they weren't originally built to, to do that. So the technical solutions to share. And we saw that in PCORnet, where essentially it is not 9 separate databases or registries or EHR systems. They're systems of systems in and of themselves, but it's one potential registry, one potential research query bank. And so I think if we solve the cultural first, the technology exists and the legal can be solved.
Excellent. Well, I'm told we can't stay beyond our time on this platform. So I just want to thank you, Donna, for this wonderful session. We're thrilled to have you on the board. And you've got a quick break, single function break. Go do what you need to do. And please join one of our 3 sessions at 11:15 on research, education, and healthcare. And we'll see you soon. Thanks again, Donna. Bye-bye.
Thank you. Thank you, everyone.